Good morning, everyone. My name is Holly Reif. I'm the Provider Relations Director for the State of Missouri Division of Developmental Disabilities, and we have a very full menu today. So this is a brief overview of our agenda. I wanted to let you guys know there are some changes to the PRT, as you can tell, and we'll get started with those, and some changes to our area assistant division staff as well. So Wanda Crocker has been promoted, and we've redesigned the way we do our ADDs. So Melissa Jones will now be over the Kansas City, Springfield, and Central regional offices. Rance Cooper will be over Sykeston and St. Louis. And then Wanda will be taking the lead for provider relations, our TCM techs, self-directed services, residential services as a subject matter expert, intake and assessment, and utilization review. Julie LePage will keep her current work. There's also some changes on the PR team. The UDAT team has changed. So Shelly Brown will be the main lead for that team, and she will be supporting 3 vendor service coordination positions. Jason, Amy, and we have a vacant spot available, which means that the Central District also saw some changes. Dawn recently retired, and there are 2 new VSCs under Nicole, Misty, and Amy. And then currently interviews are being conducted for Neil's open position as he recently retired. Moving on to the next presenter, which I believe is Carrie.
All right, I'm going to jump in since my slide is up. This is Dwayne Shoemate, and I'm the Director of Employment Community Engagement. And I believe Carrie actually follows me with eligibility. So Kat has up the slide, so I'm going to provide just a brief update on the value-based payment initiatives that are within my purview, and then just provide a little bit of an overview of our employment team. So with the next slide, with the employment reporting, again, the reporting period closed last night at 11:59 p.m. All those who participated in the initial reporting period, we just want to thank you for your participation. Again, with employment, I know we had almost 1,000 entries submitted, which is exciting, and we will be going through that process to see the ones which were able to be fully completed and that we're able to offer payment for. But again, just to kind of get the word out there, with the employment pay for reporting, it is eligible to all the employment service contractors or providers that have contract for career planning, job development, benefits planning, pre-vocational, and support employment services. The reason we're doing this particular value-based incentive is we are needing to collect a lot of data elements to inform future rate design, as our long-term vision is to move from a quarter-hour unit of service to one that focuses on reimbursement for accomplishing the intended outcomes of each services, as well as milestones in the individual's progression towards employment. That particular value-based payment is equivalent to $55 for each report that a provider submits within a quarter performance period. And for those individuals who are receiving multiple employment services, the provider is eligible for each service that they're delivering that they complete reporting on. And again, that is all done in the REDCap system. With the next slide is the slide talking about the value-based payment incentive that we have for our registered apprenticeship program for certified direct support professionals. This particular incentive is the one focusing on providing $1,620 for a direct support professional that completes 50% of the progress towards completion of that credential, and then another payment of $1,560 upon completion. And we would love to have greater participation in this program. We do currently have approximately 16 to 17 providers participating in this registered apprenticeship with over 150 apprentices already enrolled. And we are actually, as of this week, we now have 4 individuals who have completed the entirety of the program and have been awarded their credential as a certified direct support professional. So with the next slide, this is just an update of the employment team. I know the employment team is a little bit odd and unique as compared to many of our other teams through the division, in the fact that the majority of our staff are contracted staff through a third party. So just a quick refresher update. This is me on the screen. My role and function as the state lead is to be kind of the subject matter expert for all employment and community policies, the practices, processes, and strategic designs. So whether it be around the rate methodology, service definitions, coordinating contract training requirements, to our strategic partnerships with other state agencies, and looking at how we go about increasing overall employment outcomes for individuals with disability. I also do project management over a couple of different contracts. Those would be the Employment First Missouri project, as well as the Missouri Talent Pathways project. The Employment First project logo is in the center, and the Missouri Talent Pathways logo is on the right side of those 3 logos at the top of the screen. I also serve as the state contact point for the National State Employment Leadership Network. Work again with cross systems collaboration with other state agencies, as well as the governor's office. I also collect and evaluate all of our performance management and quality assurance metrics, and then develop practices and structures to elevate national best practice in the delivery of employment services, as well as coordinating employment services from a TCM perspective. And then also in looking at workforce solutions. So with our team, we only have 1 state employee underneath my supervision, and that is Sandy Kaiser. And hopefully most of those on the call are familiar with Sandy. Sandy is based in St. Charles area, and her primary role and function is to provide training, technical assistance, and consultation to the division staff throughout our regional offices. She also administers and oversees the benefits planning capacity building project we have, where we are working with Cornell University to work in helping more provider agencies to have a certified benefits planning professional on their staff and to be able to deliver the benefits planning service definition. Sandy's also there as a technical resource for other members of our employment team. She works closely with our regional offices on completion of their quality enhancement plans. And then she also works closely on integrating our Employment First and Technology First efforts. So as you move on to the next slide, the Division of DD logo disappears, and now you see the Employment First Missouri logo, as well as the Missouri Talent Pathways logo. Again, these particular areas we contract for staff through the University of Massachusetts Boston Institute for Community Inclusion. The project director of that contract is David Hoff, who is a national and an international subject matter expert around disability employment practices, policy, and training and technical assistance. So he serves as the kind of the direct supervisor of the remaining people on our employment team, and then David and I coordinate on their priorities and initiatives. So with the next slide is the team for the Employment First Missouri group. That is Jesse Kenoy, Leslie Quarles, and Nick Holtz. Again, these staff kind of serve similar to what our previous Employment First specialist would have served as. We used to have staff within every single regional office, and with budget reductions, those positions slowly disappeared. So that's why we contract for these positions. So Nick, Jesse, and Leslie's role and responsibility is to be working with our contracted employment service providers, just to be offering training, technical assistance, coaching, mentoring, to be providing opportunities to scale practice, to develop regional-based community of practices, and then also to be working with our TCMs who may have an interest in scaling implementation of best practice of how to really coordinate and have discussions around employment and factors such as benefits navigation that has a direct impact on employment. So again, these staff are there at no cost to all of our service providers, as well as our TCMs to really help embed and elevate practice. So they really are the frontline resources. With the next slide, we now move over from our Employment First Missouri team to the Missouri Talent Pathways team. Our contracted staff member on that is Jay Gibbs. Jay resides in the Springfield area, and his responsibility is to do the day-to-day implementation of the Missouri Talent Pathways Registered Apprenticeship Program. So Jay is there to provide outreach and orientation to any providers who might be interested in participating in the Registered Apprenticeship Program. He's there to do community-based presentations. He also provides ongoing training and technical assistance and consultation to those providers who have chosen to participate by really helping them embed and elevate and implement the apprenticeship program. Jay does have 2 community of practices a month. One is for the organizational, kind of the executive leadership of those sites that are offering the registered apprenticeship program. And then the second community of practice is for that frontline supervisor who might be serving as a mentor or journey worker, which is the registered apprenticeship term for a mentor. But he has a community of practice for them on how to best lead, coach, and mentor direct support professionals who may be participating in the apprenticeship program. Jay also does all of our alignment reviews to ensure that each of the participating sites are operating in accordance with Department of Labor rules and regulations. So again, even though these folks may have the University of Massachusetts Boston as their employer or within their email handles, these are folks who are working on behalf of the Missouri Division of Developmental Disability, and they're all based here in Missouri with the exception of David Hoff, who is based out of Boston. So with that, I believe that is my last slide on the update in the employment team and some of the value-based payment initiatives, and I believe I turn it over to Carrie. Thank you.
Thank you, Dwayne. Good afternoon, everyone. My name is Carrie Williams, and I am the Director of TCM Services. And today we will be covering information regarding eligibility for youth ages 18 to 19 years of age. Next slide, please. We became aware of this information, so just wanted to ensure that support coordinators were aware as well, as you may be receiving emails for follow-up. So we just wanted to walk through the process with you today. Also, before we get into details of the process, just wanted to note that when the list was pulled for this month, there were only around 18 names total for the entire state. So we don't expect this to be a large list for SCs to have to follow up on each month. So just wanted to note that as well before we get into details of the process. So as we look at this slide, as youth reach the age of 19, they will be aging out of their current Mo Health Net coverage. And currently, Family Support Division is automatically moving these individuals over into the Medicaid Adult Expansion Group, and that is that E2 group. And that E2 group does not cover waiver services. Next slide, please. So in an effort to ensure that these youth are placed in a Mo Health Net eligibility category that will support the DD home and community-based waiver services, we have created a process to identify the youth between the ages of 18 and 19 that may need to apply for the appropriate Medicaid coverage. So this listing will be sent monthly to the individual support coordinator to work with that individual in question and their parents and or guardians to apply for that appropriate coverage. So on this next slide, you see the specific directions here. And now this is what will be included within that email. If you do receive an email that you need to follow up with an individual that you're working with, these directions will be included within the email. So after that youth, go back to previous slide. After the youth turns 18 and at least 120 days prior to their 19th birthday, the support coordinators must contact the parents and or guardian to let them know to complete and submit the form. Link is here. Again, this would all be included in the email, but it is the aged, blind, and disabled supplement form. And then whenever they complete this form, that form is automatically submitted to the Family Support Division. In the next slide, it shows that if that youth is not receiving the supplemental security income or the SSI, they will need to apply. And again, those specific directions on how to apply will be included in the email when that's sent out to the support coordinator for follow-up. An application for the SSI is required before MoHealthNet based on disability can be approved. So even if they had a previous application and that application was rejected, the individual will need to apply again as the parental income and resources would have been considered before and may have been part of the rejection consideration at that time. So they will need to apply again. On this last slide, it does include an email address for any specific questions about a participant's eligibility or any questions about the process, and those should be sent to the DMH Medicaid unit. So that does conclude the update of the Medicaid eligibility for youth ages 18 to 19, and I will turn it over to the next presenter now.
Thank you, Carrie. Good afternoon. My name is Leslie DeGroat, and I serve as the division's clinical coordinator. And so I'm going to give you updates on the Missouri Health Risk Screening Tool, or HRS process. Next slide, please. We are currently in implementation phase 1. That means that all contracted DMHDD service provider and targeted case management agencies can go ahead and onboard to initiate the HRS process. In fact, we're encouraging agencies to go ahead and start onboarding now so that their agency team members can gain access to this system and then complete the trainings in the HRS system to be ready by May 1st of this year. Next slide, please. So May 1st of this year, so in a few months, HRS will go live statewide. That will begin our implementation phase 2. And what that means is that all waiver participants will need to have a HRS screen completed starting in May in preparation for their ISPs. So individuals who have an ISP implementation date of August will need to be screened in May. The screenings do align with the ISP process. Next slide, please. So for residential waiver participants, the Health Identification Planning System, or HIPS, will be replaced by HRS for that health risk identification. All assigned health inventories will be completed through the end of April 2023. Then effective May 1st of 2023, individuals with assigned health inventory months after April of 2023 will no longer receive those health inventories in the CMOR system. All open HIPS documentation in CMOR system will be closed effective October 1st of 2023. Next slide, please. I would like to point out that we have transitioned our onboarding process to a new, more automated method. We will direct you to our Mo Hurst webpage to begin the steps for onboarding. We've developed an onboarding process flow diagram also for your reference on our website because there are several steps that agencies must take to be able to gain access and also to have that information that you need to be able to move forward with that process. We have also added to our Mo Hurst webpage a new frequently asked questions document, as well as a link to the utilization review form, and then also for the process for that phase of the implementation. Next slide, please. Enhancements that we are currently finalizing are the information that feeds over to Hearst from Seymour that securely adds individuals served and with what agencies they are associated. That data feed is undergoing an enhancement, which should resolve issues that we've been seeing with users' ability to access the people to whom they provide services. We're also finalizing resources for support coordinators in regard to assisting them with discussing Hearst with individuals and families. We also have a recording that we are preparing to put out on our website as also as a resource. We're working on a diagram flow chart to help support coordinators navigate facilitating that screen, and then what other supports or services that may be identified for the individual, like how to facilitate that and how to follow up. We're also finalizing process diagrams that will give a step-by-step guide to starting the Hearst process for an individual and seeing it through all of the steps for the residential RN raters as well as the support coordinators. And most importantly, we're working on informational guides to share with individuals and families, in regard to the process. Next slide, please. I just want to add this other enhancement. It wasn't on my slide, but another enhancement that's coming to fruition is the integration between Station MD and Hearst, so that if an individual utilizes Station MD, the physician would be able to review their medications and diagnoses in Hearst, as well as their health risks to better treat the individual. And we will definitely keep you informed of that. And then here is my last slide. For any questions or feedback, please reach out at any time to MoDD Hearst Project at dmh.mo.gov. We're working very hard to respond to your emails in 1 to 2 business days. And we appreciate questions and feedback, and we're here to support you. And that concludes my portion. I will turn it over to Kim.
Thank you, Leslie. Good afternoon, everyone. My name is Kim Stock, and I'm the Director of Quality Programs for the division. I wanted to touch on a few things that are going on within the Quality Programs unit at this time. One of them is concerning the due process review committees. The division's due process review committee functions are in the process of transitioning to the Columbus organization, and the division is currently working with Columbus to outline the steps for this transition. One of the things that I wanted to highlight is that staff from the division and Columbus will be meeting with the provider agencies who are currently conducting the due process review committee function next Tuesday, March 21st. At that time, we're going to be covering the current transition outlined process and to get some feedback and input regarding the transition process from those providers that have been actively participating in conducting due process review committees at this time. Also, we are planning on having the staff from the division and Columbus attend upcoming regional TCM and provider meetings. And at that time, we want to be sharing information about the transition process, what that's going to look like, and how it could potentially impact stakeholders, and then also to receive invaluable input and feedback pertaining to the transition process. So stay tuned on this important enhancement that we're doing within the division. The other highlight that I wanted to cover today was in regards to residential RN oversight vacancy survey that we're in the process of finalizing. Who this will be applicable to is current DMH DD contracted waiver residential service providers that serve individuals receiving Division of DD 1915C HCBS waiver residential services. So contracted residential service providers. Why we're doing this effort is that residential RNs who provide that monthly oversight, they play a vital role in ensuring participant health and welfare. And the information provided from this survey is going to assist the division to identify and understand factors that may be impacting this important area of oversight. How this is going to be conducted is that an email with the survey link attached will be sent to identified provider agency contacts. How the provider agency contacts have been identified is through the current division statewide provider distribution list for residential service providers. So please be communicating to whomever you have as your point of contact for your agency to be looking for that email. The survey is going to be requesting information pertaining to important areas such as residential RN oversight status, capacity, average hourly wage, tenure, and vacancies. And we look forward to receiving the responses back. And as soon as we have that information and the survey closes out and we're able to compile the data, we'll definitely be messaging that out and sharing that information and communicating and being able to identify future strategies to address any identified areas or issues. And with that, I'm going to turn it over to the next presenter for today's call. Thank you.
Thank you. I'm Michelle Brown with the Provider Relations Enrollment and Rate Team. The Enrollment and Rate Team reviews certain policies and procedures when organizations request to add service codes to contract. By definition, policy outlines the principle under which your agency will operate and provides the framework for procedures. Policy ensures consistency and compliance with your agency's strategic direction. Procedures, however, are specific instructions necessary to perform a task or part of a process. A procedure details who performs the task, what steps are performed, and when the steps are performed, as well as how the procedure is monitored. One of the policies we review when service additions are requested is implementation strategies. While this isn't a new requirement, a new policy, we are running into a number of situations where the organizations either don't have a policy in place or the procedure isn't adequate to support the real implementation of this requirement. On the slide, you will find a link to an FAQ document as well as the ISP guide, both of which are excellent resources if you choose to review and update your implementation strategies policy at this time. Additionally, all organizations should have written procedures to support billing practices within the organization. When amending the contract, this is another policy that we will request. If you do not have your billing procedures outlined in a written format as part of your policy manual, please take some time to go ahead and formalize the process now. Next slide. Providers are also required to provide a written 30-day notice terminating services to the individual or their legal guardian, and in addition, must enter the information now into the provider notice portal. The portal is found on the DD webpage under Information for Providers button. The ENR team will request to review agency admission and discharge policies when amending the provider contract, and we are currently looking to ensure that organizations have embedded the use of the provider notice portal into their procedure manual. Next slide. And just a few reminders, as these are either new requirements or things that just don't happen all that often and sometimes require that little reminder. If you are a group home or day hab service provider and wish to do renovations to a group home or day hab setting, those plans have to be prior submitted to the state fire marshal for approval before any construction or renovations begin on the setting. On the slide, you will find the CSRs, which go into details on those fire regulations. Out-of-home respite is now required to be added to a provider's certification. We have a number of group home service providers who have already received approval through the division to provide the out-of-home respite service at the group home setting. And at the next licensure and certification renewal, these organizations will need to also request certification for the out-of-home respite service. Next presenter, please. Thank you.
Hey everyone, I'm Emily Lubring. I'm the director of the Federal Programs Unit, and I'm going to give a update on our HCBS, what's going on in HCBS world, which is everything, but everything we do, but specifically from a federal standpoint and state standpoint. So next slide. The first thing I want to talk about is the end of the PHE. the federal administration plans to extend the emergency declaration to May 11th of this year, and then the emergencies will end on that date. This provides us a opportunity to resume our Medicaid HCB operations pre-COVID. Also, a reminder that our 1135 flexibilities expire upon the termination of the public health emergency. Our Appendix K flexibilities expire no later than 6 months from the termination date of the federal public health emergency. So we're looking at November for the expiration of our Appendix K flexibilities. And I would encourage, if you are still using some of the flexibilities and haven't, gone back to all of the normal operations in some cases, please be sure to use the COVID-19 flexibility authority chart that is linked in this presentation. This chart provides you with each of the flexibilities, and then if it's an Appendix K flexibility or 1135 flexibility. Next slide, please. So a couple updates on value-based payments, and Dwayne did go ahead and provide what's kind of updates from an employment standpoint. Just as an overarching update for value-based payments, just this slide right here gives a lot of resources for value-based payments. You have your value-based payment website. That's very important. That includes your VBP incentive chart, and it provides information about each of the 9 incentives with the metric for the incentive, the amount that is paid for the incentive, how often are the reoccurrence of the incentive. We have some incentives that are just like your NCI staff stability survey. That's a one-time payment each year for completion of the incentive, which, by the way, I want to remind the date on the date that the NCI staff stability has to be completed and the request entered in REDCap for that survey is April 30th. So if that's one of the incentives that you want to participate because you already do the NCI staff stability or you're planning to do it this year, that incentive you want to get finished by April 30th of this year. Now, you can still go ahead and complete the NCI staff stability after that time. It's just not eligible for the incentive. That incentive chart also provides you how often it occurs. So maybe it's a monthly, quarterly, or twice a year incentive, or what services that are eligible for the incentive. All that information plus helpful links is in that VBP incentive chart, kind of one place to get your basic information for the incentives. Also on our website, we have a provider training. Some of the one that's very popular right now is the REDCap or the data collection training, because we have started that process of the providers entering data into REDCap for the incentives. And the first time period that we had, which was July 1st of 2022 through December 31st, 2022, which is the first performance period, we had providers enter data in. That just closed. The reporting time period for that period closed yesterday. So we are starting reviews. Guidehouse, our contractor, is starting the review process, and then we'll move on to the actual payment process for those incentives. We also have a question response documents out there, kind of think FAQ or just some questions that we get about our incentives and then the responses that we have. And that's from kind of a historical standpoint. Some of them are from questions that we got, at the beginning of the process, and we've added questions onto that throughout the implementation process. And then mentioning the VBP mailbox again, the dmhdd.vbp. So the questions can be sent to that mailbox. And it has been very active with providers sending questions about the incentives and where to find information as well. Talked a lot about REDCap. Here on the screen, you have the REDCap user access request link. Currently, waiver providers are the only ones using REDCap. We are opening up REDCap in the very near future for our TCM providers to enter incentive data for the Hearst incentive. And then also we have the login page. So the link to log into the REDCap page where you will enter data for the incentives. And just a quick timeline, the REDCap, I mentioned REDCap closed for initial performance period from July 1 of December 31st yesterday. And then it's going to be opening, I think, Dwayne might have mentioned this too. We're going to be seeing another opening of the incentives come April 1st. Those that are quarterly and then the one that's monthly, it'll open on April 1st as well. So we'll be turning around here in a couple weeks and starting a new reporting period. So next slide. Just a quick update on our waiver renewals. We have the Partnership for Hope and MoKids renewals and then this includes amendments for the comp and CSW waivers to align with the same changes we make to Partnership and MoKids renewals. And the same changes throughout all four waivers when applicable. Those will be effective July 1st of 2023. So MoHealthNet, our Medicaid agency, will be submitting those waiver applications to CMS by April 1st of 2023. And then we, like I mentioned, expect CMS approval by July 1st of 2023 for those waiver renewals and the amendments to go along with them. Next slide. Quick update, or not really an update, just a plug for our EVV requirements. If you are a PA provider, you are required to have EVV or electronic visit verification in place for PA visits. That went live in November 1 of 2021. MAC is imposing sections for providers that are not connecting to the aggregator, meaning they're not sending EVV record data to the state aggregator where it's collected from all the providers. And just also, if you are sending data, you have a vendor that is sending data, please be sure that you are checking up on that vendor. Make sure that they are actually sending data, that it's getting accepted. There's also a portal, the aggregator portal, where you, as the provider, can go in and look at the records that are being sent from your agency to see if there are things that are missing, things that are being declined or rejected. You can actually you really need to monitor as a provider to be sure that the data is going over. And then all PA visits require a verified EVV record, kind of mentioned that. We do have, and this could slightly be old. We had about 86 out of the 185 providers that are currently billing PA that have not successfully transmitted verified records to MHD. That was probably from December when we ran that data. 86 out of the 185 billing were not sending records. And then just lastly, a reminder that the memo field is something that is required. There does need to be a note entered for the PA visit. And there is a requirement of vendor, if it only allows 1,024 characters to be transferred to the aggregator to be accepted. So vendors need to be able to don't send more than 1,000 characters, 1,024 characters, or it will be rejected and may not come across, not accepted. So those are things that you, as a PA provider, would have to be in contact with your vendor to be sure they know the criteria around the memo field. Next slide. And then I think this is my last, kind of my last update, but there's quite a few slides on this part, but I'll go through them. I won't be reading everything on each of the slides in the next couple slides that I share about the visits that CMS have been conducting with states. But the HCBS settings rule that we've been talking about for years, that transition period is ending at a federal level for the settings rule. That transition period ends on March 17th, which is tomorrow. And all providers are expected to be meeting the requirements of the HCB settings rule. All of the basic human rights that are required for our individuals for and making sure that all of our HCBS sites where services are provided are compliant with the HCBS settings rule. Now, the transition period is ending. One thing that CMS did allow states to do is request a corrective action plan, or for short, a CAP, for their state if there were some lingering regulations or policies that hadn't been completely updated or approved. So Missouri was one of 10 states that was not going to request this CAP. We've had our statewide transition plan approved for many years. We've done our assessments of sites. We have policies around HCBS baked into our rules. However, when we attended one of the webinars, it was pretty clear that CMS wanted all states to really consider the use of a CAP to go to, if you weren't a state that had originally requested one, to really consider if there were anything else that might be that you need to take some time to be sure that all of your policies have been approved. So Missouri did go ahead and decide to request a CAP. And what that will allow us to do is to finish up a couple of license and certification CSRs that are currently with the governor or almost to the governor's desk that need to actually be approved, full on approved. So, and if you're familiar with any updates to CSRs, it can take a while. So we are taking this time under the CAP to finalize CSRs, and as well, our partner DHSS has a piece of this as well for the HCBS settings rule and review guidance. So that's why if you hear about an HCBS CAP from Missouri, that's what it's for. CMS talks about the non-negotiables, and that is the rule itself for human rights, ability for individuals to choose where they live, where they sleep, where they eat. Those kind of things are not negotiable. That is not part of this corrective. Those things are to be in place by March 17th and should already be in place. So we are allowed some time to finish up some CSRs and review some more guidance to be sure all of our guidance is currently up to date. So that's a little bit background on the HCBS transition rule. And then I also wanted to share something about the CMS visits. CMS has started state visits for heightened scrutiny, and they have planning about approximately 15 state visits in the year 2022 and 2023. They're about halfway through that. They have about 8 more to go, I believe, in 2023. And they conducted tours of the settings, reviewed ISPs, reviewed documents on the site, and they speak to the actual beneficiaries or the consumers or individuals and the direct support professionals at these sites. Next slide, you'll see where CMS provided positives that they have seen in their site visits, and mentioning that statewide training programs were implemented for HCBS rule. Opportunities for choice and community engagement were seen in these states despite the workforce shortages, and settings were able to provide individuals access to allow visitors and meals options and snacks and that sort of thing. So they did see some positives, but the next couple of slides I'm going to go over are some trends that they saw that were not positives and that needed to be worked on. So if you go to the next slide, these are the ones that I'm not going to read everything on the slides. This will be available in this presentation, but also we'll be sending out a blast shortly to kind of link this information for our providers, just so you can kind of study up. Here are the things that CMS is seeing and things that you should see as a provider if you have any of these things that you need to work on. Settings. And for instance, for our ISPs, settings that did not have a current ISP for the individuals that did not participate in plan development or signing the plan, providers using provider-specific plans of care instead of individual's plan of care, and plans not recording the individual's preferences, their goals, or choice offering. So those are some of the things that they saw in trends in other states. They have not been to Missouri to do any on-site visits. Next slide. Some trends that they saw with provider staff training that examples that responses to questions described differences between when they talked to staff and administration and DSPs. They found that not all of them were aware of what the HCBS settings requirements were. And often individuals might talk about the HCBS settings role more as the difference between institutional setting or community setting. And really what they're looking for is to be sure, rather than relating it to the community integration piece. And then next slide. For community integration, they saw where HCBS settings exit and entrances that are connected to institutional settings are located at the entrance of an entrance to an institutional setting. So those entrances were together, and settings should really plan to reopen to separate entrances once the pH protocols are lifted. So they did reference that one back to potentially being related to COVID and limiting the entrances and exits for purposes of COVID. Next slide. And then for trends that they saw or themes they saw, community integration and for employment and activities, providers referencing groups that take place offsite as community activities, even when the individuals are not really integrated into the broader community. Examples would be attendance to a dance, a holiday event that is only for individuals that are with disabilities who attend the provider's agency programs or campus. So also individuals should be offered individual opportunities for meaningful engagement in community life. And they found with employment, participants expressed a desire to work, but there was nothing related to employment services in their ISP. Next slide. For provider-owned and controlled settings and access to visitors, trends they saw were CMS found restrictions on visitors posted at the setting or in the lease agreement, policy or practice to restrict visiting hours, prohibit overnight guests, or limit the number of guests or visitors an individual can receive, and requirements to get approval to have guests and infrequent guests, or just no guest at all. So those were trends that they saw that were concerning and needed to be remediated. And then the next slide. For leases, residency, and other written agreements, CMS found restrictive language in our lease or residency agreements that was inconsistent with typical lease agreements. Examples of this might be that they had to work on the provider's work site, they pay the provider for lack of attendance to a work site, move out during specific periods of time, or be evicted if the individual's needs increase, even if resources were available to provide support to that individual. And then next slide. Additional examples of provider-owned and controlled settings as such, settings that were not formally owned, identifying settings that were not formally owned by the provider. CMS reminds states that the individual regulatory criteria also applies to settings controlled by a service provider. This includes scenarios in which a provider has influence over whether an individual is accepted for residency, or when the landlord has influence over the provider for the individual lease. So really identifying when it's really truly a provider-owned setting. And then last slide. For themes and identified were related to modifications or additional conditions, rights restrictions. So CMS found that restrictions were in place that did not adhere to the regulatory requirements. They were not supported by a specific assessed need for the individual or justified in the individual's person-centered plan, and therefore not permissible under the regulations as an individual modification. And a reminder that restrictions must go through due process and be documented in the ISP. And some of those things they mentioned were locks on bedrooms or bathrooms, restricted access to the community, or behavior plans that required individuals to earn the right to have activities in the community. So those were just, that was my last slide. I know I had a lot for our HCBS updates. So those were the items that I wanted to be sure that we hit on from a organization, from a division standpoint on the HCBS settings rule. I'm gonna go ahead and hand it over to the next presenter.
Thanks, Emily. Hi, everybody. This is Leslie Bradley with Division of DD Federal Programs Unit. And I just wanted to give a quick update on the Missouri DD Health Home timeline and the initiative. The division, as you can see, began planning and researching the DD Health Home initiative in 2017. And this program is being designed in collaboration with the Missouri Department of Social Services MoHealth Division. And it's intended for individuals statewide served through the Division of DD. And this includes individuals in a waiver as well as non-waiver individuals. Individuals will have to have a qualifying chronic health condition and a healthcare level indicating increased health-related risk or destabilization. The DD Health Home will provide care coordination for enrollees while integrating care management of chronic conditions and other identified health risks for population health management. Providers of the DD Health Home will be contracted TCM providers and HCBS waiver providers. I've included in the chat the link to the DD Health Home webpage, which provides informational webinars, DD Health Home eligibility requirements, as well as links to Missouri's 2 current health homes, the Community Mental Health Center Healthcare Home through DMH, Division of Behavioral Health, as well as the Primary Care Health Home through MoHealthNet. And this slide, as you see, provides a very high-level view of the DD Health Home timeline. The draft state plan amendment was out for informal public comment last October into November, and the draft CSR public comment just ended March 8th of this year. In January, the governor did include this initiative in his budget recommendation. And again, this is very high level. We have many milestones ahead of us, and we continue to work towards an implementation date of January 1st, 2024. If you have any questions, feedback, or interest in knowing more about the DD Health Home, please email us, and I have included that address in the chat as well. Thank you, and I will turn it over to the next presenter.
Good afternoon, everybody. This is Toy Wilde, and I'll also have Travis West, who will be doing our updates around connection in our interoperability projects for the division. Next slide, please. Okay, so I'm going to start out with, we've got 3 different projects that we're going to go through today. So I'm going to try to make these really clear. They kind of all align with each other, but just wanted to kind of clarify the distinction in these projects. So we have our first update that I'll go through is our connection case management implementation project update. So that's the implementation of the case management system that's going to be coming live later this year. So we'll talk about that. And then as far as our interoperability projects, we have 2 projects where we're working with MoHealthNet and the health information networks in the state of Missouri. One of those projects is the HCBS provider HIN onboarding project. And Travis is managing that project, and we'll be giving the update there. And then I will be going over our ELTSS, so too many S's, the ELTSS implementation project. And for folks that are familiar with, you've probably heard of the LEAP grant project that we did. It's basically taking what we did in LEAP, and we're going to implement that in a live production environment. So next slide. So as far as connection, our project status update, we are currently somewhere around 88% complete. I will be fully transparent. Current go live is scheduled for July 17th. I will be honest, you should be receiving announcements and more formal information next week. We are going to have an update to the project schedule and timeline, so I'll be sharing more updated information. Once that project schedule has been vetted and approved, we'll send out further communications. Currently, right now in the project, we are complete with the startup phase and the planning phase. We completed that quite some time ago. For phase 2, which says that design, build, and configuration phase, we'll be concluding that section of the project and be at 100% by 3/22 of this year. And we are really heavily focused in the testing phase, preparing for the deployment implementation, preparing for training, and then we've been doing CMS certification activities, which is a part of that phase 5 stabilization and certification. We've been doing those activities throughout the duration of the project. So that's kind of our main focus right now, is all of the preparation activities that have to happen around CMS certification of the connection system. And we do have a very formal presentation that has to be done to CMS somewhere between the 4 to 6 week time frame before we go live with the system. And then closeout will be at the conclusion of the end of the project. And traditionally, that's when the system goes live. But in our case, since we're certifying the system with CMS, that'll be about a year after the system goes live. It takes about anywhere from 9 to 12 months to completely certify the system with CMS post go live. So I will have you go to the next slide if you don't mind. The connection data diagrams, I want to take a minute. Sometimes I think visual can be really helpful. So I wanted to kind of put together, there's a lot of integrations that are happening in this project. So there's a lot of interfaces that we're developing between connection and other systems. So I wanted to just take a quick second to talk about how those 10 interfaces that we have with connection, how we're going to send and receive information and transfer data between, for example, Seymour to connection and some other of the systems that the division uses as well to populate the system with the data needed. So basically what you have in the center there, and I'm going to kind of go from the center and then I'll move kind of clockwise through this as best as possible. So connection is the main system now that we have for case management. So what I wanted to kind of influence here is that Power BI is kind of the reporting module that we have that's powered within connection. So that's how our research analysts and data folks are going to be building and doing those reports inside of connection, is going to be through an application called Power BI. Then we have, I'm going to start with the CCA interface. So that's the common client area. That interface currently is sending data to Seymour. Going forward in the future, CCA, that common client data, which is like the DCN and identifying data, it's going to go to connection. So we do have a one-way interface there to be able to receive that common client area data. The next one is HRST, or inelectability. However you reference that, we are going to have a bidirectional interface with HRST and inelectability. So we're going to make sure that the individuals, the waiver individuals, are in sync between both the connection and the inelectability system. So that's that bidirectional piece. And then we will have a subset of, I think it's service considerations. And Kim, if you're on, hold me honest here. I think it's the service considerations are going to come over into the connection system. Plus, we'll have all the HRSP plans that will come over into the connection system. So that's kind of the information that we'll receive so that it will help support the planning process and you have those screening planning results. The other interface that we have is the SDS Acumen. So our fiscal agent right now is currently Acumen. So there will be a two-way direction between Acumen to get all of the self-directed services fiscal agent data. Then we will have a two-way interface between MMIS, which is our Medicaid system where we process all of our Medicaid claims and billing. Then SSA, we will have an interface with the Social Security Administration to get our Medicare data. And currently that there is an interface with SSA to Seymour. We're just adding the addition of getting that information now directly to connection. We will have a subset, you see two Seymour boxes here or round cylinders. I wanted to kind of distinct this. The one that is a single way interface where the arrow is just pointed to connection is basically for consumer banking and EMT. We will be receiving a subset of the data from Seymour to populate into connection. So it gives service coordinators, providers, appropriate roles in the system, data and information they need about those, because EMT will still all of your incidents and investigations data will still all be entered into Seymour EMT, and consumer banking is still going to function within Seymour. So then you have the bidirectional cylinder for Seymour. And this is basically where I would kind of lump this together as non-Medicaid claims. It's also our pre-encounter information for registering folks and making sure a baseline episode of care is populated in Seymour, but most of your demographics data in what would be in your normal episode of care that you think of in Seymour is now going to be, the primary source of that data will now come out of Connection. The provider contracts will be a two-way interface. Those are currently populated in Seymour, but they will actually originate from Connection. And now a subset of information will be sent back to Seymour so that Seymour can function off of that subset of data. And then we do not have a direct interface with Connection to SAM2. So Seymour is still going to process and handle those payments that go directly to SAM2. It's our link to that SAM2. Last but not least, we will be sending a complete replicated copy of Connection to our DMH data warehouse for more holistic DMH reporting and backup. We still have the use of Tableau. I'm sure many of you have seen Tableau reports from the division, so we'll still have use of that, that application to create reporting. And then we will also have an ad hoc layer or database out of Snowflake for ad hoc reporting for Connection. So this gives just a little bit of information here about, I know some of this was technical, and I understand that. If you guys have questions, you can let me know. Definitely make sure and chat in anything you have. But this just gives you kind of a nice idea of what's coming and what's interfaced with Connection. Next slide. So this is the EDI companion guide. It is linked out on the Connection webpage. I wanted to draw a little bit of attention to this as, you know, when we go live with the Connection system, I really wanted to make sure that providers had the full information of, you know, we're really truly replacing all DD waiver and purchase of service billing is going to happen in Connection, and that will be replaced with what we currently do in Seymour. So Connection will still support that electronic submission of claims as well as online manual data entry into the system. Wanted to really encourage those providers that either are currently electronically batching their claims over to Seymour to check out and make sure that their vendors have that Connection companion guide and this Connection claim error codes list. It's important as we switch over from Seymour. If you want to continue this process, FEI will onboard with provider vendors that want to electronically submit their 837s, 835s. So just wanted to share this information. I also wanted to share too with folks that it's an open invitation for providers who may not currently electronically submit their claims, that there's an open opportunity to do so with Connection and encourage that. So if you guys have questions, please feel free to reach out to myself or Dean. And then I did want to just mention real quickly for TCM providers, there will be billable case notes that will be required to be documented in Connection. And we actually just most recently went over that workflow in the February Connection walkthrough. Next slide. Okay, so this is busy, but it's again a way that I wanted to show visually how the flow of delivered services will run through Connection. So you see those waiver POS providers, you have all of your different buckets of programs here. You submit your 837 electronic claim. It goes through the validation process in Connection. The claims then are processed and goes to MoHealthNet. This is a really, really great slide too for folks. If you're not the person that does the billing in your area, definitely take this back and showcase this to, you know, your billing group or whoever does that within your organization. This would be really helpful. There's also, just for folks, I don't want folks to feel like you're pressured and there is no option to manually enter your data for delivered services. You will absolutely have that option in Connection to manually enter those as well. Choices for families will be online data entry. It goes into a service event in Connection, and then you can see the flow there. And you can see how what is going to be sent between Seymour, MoHealthNet, and how Seymour is handling that SAM2 financial or Office of Administration processing of those non-Medicaid payments. And then you can see the flow of the TCM provider with the case notes, how that then is a service event, and then we'll flow over. So I hope that visual makes sense. If you have questions on that, don't hesitate to reach out. Next slide. So now I'm going to turn over to Travis to do a update on our HCBS Health Information Exchange Provider Onboarding Program.
So, and good afternoon, everyone. This is my first time on a call like this, so it's nice to see a bunch of new names. My name is Travis West. I work for TOY as a project manager on these different projects that we're covering this afternoon. So it's great to be here. Go ahead and go to the next slide, Holly. So I want to talk a little bit about Health Information Exchange onboarding. The division has sponsored what we're calling an HCBS provider onboarding program to Missouri's Health Information Exchange. That's going to take place over the course of this calendar year, 2023. We actually kicked this program off just after the new year back in January, and we sent out some information at that time encouraging participation for providers who serve individuals with developmental disabilities, because it really is an exciting opportunity that doesn't come around all that often. It's actually not the first Health Information Exchange onboarding program of its kind. The Mo HealthNet office at the Department of Social Services sponsored a program back in 2021. There are a little bit of key differences between what Mo HealthNet offered and what we're offering. Mo HealthNet offered a broader program to Medicaid providers and healthcare providers across the state. But what DD is doing this year is targeting specifically the HCBS provider population so that we can make sure that we are bringing you into that sort of data exchange infrastructure to specifically benefit the individuals that we all serve. So before I get too far into the weeds, I do want to start at the top and talk about Health Information Exchange, because this is not necessarily a term that gets discussed on regularly. So a Health Information Exchange is fairly simple as a concept. It is simply exchanging health information electronically between providers. So what does this mean? This means that when you go to the doctor, your doctor probably has access to your medical record from a recent hospital stay, your pharmacy, physical therapist, occupational therapist, any clinical visits that you've had other than that physician's office, and it goes on. So it's a collection of data from all of the different providers that provide you care. So the idea is that they don't have to make phone calls, they don't have to send faxes, they don't have to go through extra steps to get your information. It's shared freely so that they're better able to make decisions that benefit you. They're not conducting duplicative tests that you may have already had recently. They know what medications you're on, when they were last filled, where you had them filled. They know who prescribed it, and it goes on. So it's just a lot of benefit to being able to share that information. Sorry, can we go back to that last slide? Thanks. And so the division sees the value in that. And what we've done is we've created this program in partnership with Mo HealthNet, because as I said, they sponsored that program a couple of years ago. And we've made available 20 slots for our HCBS provider community to come on board, where the division is going to pay for that connection. So what will happen is a participating provider will connect with one of 4 health information networks who make up the broader concept of Health Information Exchange in Missouri. And they'll work with that health information network to connect their agency's information technology to the health information network. And that will facilitate the exchange of data. So then that provider who participates in this program will be able to receive data that health information network collects from other providers of all different kinds across the state. And your agency or the participating agency will be able to share information with the health information network so that it's made available to providers, like I said, in hospitals, clinics, and so on. Next slide, please. This is a graphic that I tracked down, and I thought it was a good representation of how a lot of folks regard Health Information Exchange today. And you'll see here, it's a good graphical representation of what I was discussing earlier. So Health Information Exchange is a way to connect a bunch of different providers. So on this image, we've got a specialty physician, local health department, community health center, primary care, and a hospital. And you'll see 3 letters there at the end, EHR. That stands for electronic health record. And that's simply a representation of their IT system. You may not have an EHR. You may use a case management system or some other system that you don't refer to as an EHR. But at a broad level, the concept is the same. They have IT infrastructure that they connect to each other through the HIE ecosystem to be able to share data. And I got a little fancy with this slide if you'll click just one more time. So this image here is what you'll find on a Google search. And what you don't see there is home and community-based services or long-term services and supports, because traditionally it's not been a huge participant in health information exchange. It's been more of that acute care and primary care environment. So what the division is trying to do is trying to drum up more participation in the personal care space, the long-term services space, to transform health information exchange in Missouri to include that subset of care that we all care so much about. So we're going to onboard 20 new providers. And as of today, we've already secured 18 of those slots. So there is still time. If there is somebody on the call and this is the first time you're hearing of this, you're not out of luck just yet, but you do want to move fast if you want to secure a slot to participate, because we have filled 18 of our 20 slots, and we'll be kicking off some contractual language and agreements and things like that towards this coming May. So definitely don't delay at this point. If you have questions, we do have a website, which I will post in chat, that will include an email address and inbox that you can send questions to. It also has links to our program guide. We have a flyer we made, and it also links to MoHealthNet's site to talk more about health information exchange. But hopefully at the end of this year, we're going to have 20 new HCBS providers that are now part of the health information exchange ecosystem. And that's a big deal. It seems like a small number, but when MoHealthNet ran their program 2 years ago, they pulled in 6. And there could be others that have already onboarded using their own funds. But my suspicion is that's a small number. So at the end of the year, we're going to have hopefully 26 providers, whereas today we have 6. So it's a huge increase, and we're just going to keep looking for opportunities to increase that number over time. But like I said, this is a great opportunity. And if anyone's on the call that's already participated and locked in a spot, congrats, and I'm glad to have you aboard. Looking forward to working with you. And I'm sure the health information networks would say the same. Next slide, please. So this is some, information on what we're doing. So like I said, we have 20 available slots, 2 more remaining. We actually started with just 15, but we filled those 15 slots so much that we were able to go back to division leadership and beg for money to add more space to the program. And we were able to do so, and we added that extra 5 slots to 20. Like I said, the efforts are going to continue throughout the year. Right now, we're just collecting interest from providers. We're signing documents that say, yes, I am ready to participate, and I am ready and available throughout the year to participate in program activities. We have different milestones set up throughout the year where we're going to actually connect you to a health information network. We're going to start collecting data, reporting data to see how it's going. And then at the end of the year, we'll kind of close out the program with lessons learned and talk about the value that's been added to those that are participating. And there at the bottom, that's the most important part. We want to fill all 20 slots. I think we're going to, but if this is something you're excited about, definitely reach out sooner rather than later. We're expecting to fill these slots in the next couple of weeks at the latest. And like I said, I'll put that link to our website in chat. And my last plug will be for the division's email blasts. If you have not signed up for those, please do so. We sent out our program kickoff announcement in January through that system. And then we sent a reminder, I think in mid-February, somewhere around there, to let folks know that there was still time to join up. So definitely a good resource to have if you don't already. So with that, Toy, I'll kick it back to you for ELTSS.
Thanks. Okay, so I want to address just a couple questions that came in chat, and I'll make these quick. There's one on training and how training will be approached with Connection. The Connection training is a train the train module. Train the trainers will be division, a combination of division, and a subcontracted company called Educology will provide the other subset of trainers. There's a total of 24 train the trainers. There will basically, like I said, there's a portion of those are division staff and the other portion are from a company called Educology. FEI Systems, who is our vendor for the case management system, is responsible for the preparation and the activities to train the trainers. So the train the trainers will have a month-long activities of getting completely trained, brought up to speed, and prepared then to be able to go out and execute over a 2-month time frame end user training. So as a provider or a TCM or let's just say a service coordinator, state service coordinator, anybody that's going to be an end user in the system, you will participate in end user training. End user training is, we're working on all the schedules, we're working on all the information. It will be sent out to you directly. So we're in the process and collection of finalizing the list of every single end user of the system. You will be sent out a specified information on how to sign up for training, when training will be, all of those specifics and details. We will also be conducting in the April-May timeframe for anybody that has been identified as a specific end user of Connection. You will be invited to participate in 2 different webinar opportunities to go over all of the specifics. They will also be recorded as well. So that's how we're doing it. Typically most trainings we have 8 basically training courses. Typically those trainings are 1 day in seat. And we have those 3 regional training areas. So more information to come. I'm about to update the timeline on the end user training. So I don't want to share dates today, but I promise they will be shared next week. The other question that we have is around does the TCM need to sign up on this, or will this be integrated in Connection? So the onboarding program is separate from Connection. The reason I would say this is separate is that you're entering your data into Connection. The onboarding project really is about receiving additional information about the individuals you serve from other acute care or different types of primary care settings. So think of it that way. Connection, you're entering and you're using that information to plan care, where the onboarding program Travis talked about is your system. If you have an electronic system that you use to do case management or whatever services you provide, you would receive information or be able to get in and get additional information about people by connecting to that HIE. So I hope that makes that a little bit clearer. So now I want to talk about the ELTSS implementation project. This kind of brings things full circle. This is the way we're trying to take what information that we collect in Connection, because most of this ELTSS data set, which stands for Electronic Long-Term Supports and Services data set, is basically comprised of a lot of the data that we enter in our service plan. It's our demographics data. It's lots of different data that makes up this ELTSS data set. The goal of this implementation project is to actually push this type of data so that a HIE or a HIN would be able to have this data in their system, so that acute care and primary care providers, other providers that are connected inside of a HIN, could pull this information on an individual. So next slide. So why is this important? To me, it always comes back to the why. So the why is super important. We have a really disconnected ecosystem. So managing inconsistent information across provider systems is something of constant that I know providers are struggling with all the time. There's lack of adoption and maturity of standards around interoperability. And when I say interoperability, I'm really truly meaning you share openly data between systems. Lack of sharing financing to support social care integration across health and social care providers. So this is something we truly see. Let's say an individual goes into the ER uses an EHR, but they don't have the service plan. If they're connected to a HIN in the state of Missouri, and we do this project successfully, what could happen is that individual that's being served in the ER, the doctor could then go into their EHR, query for the ELTSS data, get information that's off of their individual support plan, and be able to better applicably take care of that patient and administer treatment without having to wait, let's say, for a paper documentation or a support coordinator or a care manager to get involved in that process. Right. The HIE onboarding program is optional. It's up to you. It's a way as a provider to receive additional information. It is not required. That is correct. So solutions. The solution to the problem that I just stated is really building more digital solutions that connect our disparate systems and ensure they work together. We want to be scalable, have practical models that implement these required standards. So in order to do this, one really nice way is if we connect providers to health information networks, which is one of our key goals in that HCBS HIN provider onboarding project, we can continue to build that trust, convene stakeholders, and make sure that data is very meaningfully shared between the health information exchange. Next slide. So project contacts, you guys have heard a lot about LEAP over the time frame. You know, during the LEAP, we were awarded the LEAP grant through the CMS Technical Assistance Program. We spent time doing this leading edge acceleration project. During that time, we really focused on, the award was given to us in Area 3, where we were looking at integrating healthcare and human services data to support improved outcomes. What really came from that is we were able to successfully test sending our ELTSS data, which I would say a massive subset of that is the ISP plan, to a HIN, and then that HIN was able to share it with other electronic vendors. So it was really, really exciting, and nationally that had not been tested. So it was a really cool thing to happen. Next step, or next slide. So what we found through that testing process is that there's really a benefit to the Medicaid population. We saw the ability for improved care coordination. So persons served will, basically benefit from a more coordinated, efficient care between coordinators and providers. There was better care for individuals with complex needs and conditions. We had improved data quality, and it would lead to cost savings. Next slide. Benefits for the state, it really aligned state programs and priorities. So through implementing the LEAP use case, the state will be able to better establish that data exchange capabilities that really our providers, individuals, and everybody's really looking for. We want to do this through the HIN network because that's really the best platform to do it through. It will increase the use of technology among the DMH populations, which we know is very disparate, and it will promote longer-term interoperability among our Medicaid technology systems. And this should just lead to better Medicaid data and analytics capabilities that the state can provide. So it'll also improve efficiencies and advance health equity across the state. That's one of the things that I love about this project is it really right now in the health information exchange and interoperability world, the ELTSS data set and most of the social determinants of health data sets are really inequitably shared. So this really gives us an opportunity to help start bridging that gap, and it shapes the national landscape. These type of projects and implementing this will help us pioneer and help us demonstrate for other states and other folks how you can real world implement sharing long-term supports and services data and how it will help in efficiently improving quality of care and hopefully improving those outcomes and reducing administrative burden for providers. Next slide. So this is our project timeline for the ELTSS implementation project. We're hoping to be basically live in March of 2024. We're in the process of working through all of our contractual pieces, gathering our data, making sure that we're mapping our data. It's really a massive integration project is what I would call it. And we're working with the 4 HINs in the state of Missouri to try to engage all 4 to participate in this project and receive this data set. And then working with providers that they serve to make sure that providers and their electronic health records start to be able to ingest this information. So it's really exciting. We're hoping that some of the providers, the HCBS providers for the division, will be able to also participate in this project and be able to consume some of the data coming back. That would be an exciting feat. So this is our overarching timeline, and we're looking forward to working through these pieces. Next slide. I think that's all I have, so I'll hand it off to Wanda.
Thanks, Toy. Good afternoon, everybody. I'm going to introduce you to a little bit of information about the Columbus organization. Hopefully you all have providers anyway, and hopefully TCM administration have received invitations to our walkabout the last week of March, first week of April. So we want to give you a little preview of what that's about and who Columbus is. So many of you are aware that prior to COVID, we posted a request for bid for provider review of services. Kim was referencing this contract earlier today on this meeting when she was talking about mortality review and due process. What I'm going to expand upon is the rest of the Columbus bid organization. So we had placed that bid out there on the web prior to COVID. We were just about ready to award it when COVID hit us. So we pulled it back because, of course, a lot of things impacted our ability to go out and do provider site reviews. So we were able, with our emergency funding funds, to repost it, and Columbus bid for that bid against the IFB. Sorry, I'm getting my initials all twisted up. And they were awarded the contract. So that was awarded in December. Columbus is certified as a QIO-like entities for Centers for Medicare and CMS, clinical standards and quality. Combined, they have more than 38 years experience with 3 areas of focus. One in the quality improvement services, which is what we are looking for them to do here in Missouri. And they currently have 8 other contracts across 6 states for similar supports that they're going to provide to us in Missouri. They also do case management services directly as a provider, and they are in 7 states providing that service. They also provide professional clinical staffing to agencies. So next slide. We are lucky today to have some of our members from Columbus with us. And so if they're able, Dan, Beth, and Elin, if you wouldn't mind coming off of, come on camera so people might be able to see your lovely shiny faces. Not sure if they'll be able to or not.
I can't speak for them, Wanda, but I know they're listening. How about that?
There we go. Well, Dan, thank you guys for joining us. I thought we would just take a little bit instead of my just saying your name and just give you a chance just to talk to the crowd and introduce yourself real briefly. And Elin and Beth as well, if they're able to. If not, then they'll hopefully get to learn more about them at the end of the month.
And I will certainly, if they can't join us, I'll introduce both Beth and Elin. But thank you, Wanda. And my name is Dan Howell, and I'm privileged to be the project director for the Missouri project. We have a number of people that we're bringing in that have a wealth of experience, both at the state level with state former directors, former case management owners, nurses, physicians. People have spent most of their careers, in fact, in the intellectual and developmental disability world to help assure that providers of both TCM as well as residential and day services for people with intellectual and developmental disabilities they're doing a great job now. We want to make sure they continue to do that. And there's really 4 elements that we'll be working on. Number 1, as Kim alluded to earlier, it was a due process, and we'll be taking over a majority of the functions within the due process committee structure and role. Mortality review, we're going to be assisting on the front end of the clinical reviews for mortality review for people who do pass and they have an intellectual and developmental disability. Third is targeted case management. We've been in the month of March shadowing a couple different provider entities, and then sometime in middle April, we will begin in earnest assuming the role of the targeted case management annual reviews. And then lastly, but not least, the provider reviews. We've spent a considerable amount of time utilizing the tools the department has and expanding on those. And one of the things that Wanda talked about is in the walkabouts, we'll be talking about some of the expansion of the tools, and we are going to be piloting the project starting in April with 4 state-operated habilitation centers and 4 providers who have graciously raised their hand to see how the new tool will be implemented. So with that, Wanda, we're incredibly excited to partner with the division and work closely with the providers, both on the TAC and on the TCM and the provider review side.
Thank you, Dan. And I did see that Elin and Beth were able to come off, but they might not be able to see your face unless you say something. So how about you say howdy and let them get to see your face?
Sure. Hi, Beth Reiniger. I'm the Vice President for Quality Improvement Services at Columbus. I've been at Columbus for over 30 years, so I've worked on a number of projects of a similar scope to this one. And I just wanted to say that, the team has been so great. Wanda and her team, everyone we've been working with has been so great to get this project started. And we're really excited about partnering with DMH on this, extremely important project.
And Elin? You're on mute, my friend.
And
there you go.
To get the project off the ground. And we look forward to meeting all of the providers. Most of us have had extensive experience in working in positive ways with providers and working with providers that sometimes have issues that need to be addressed, and to do that in positive and constructive ways. So we're really excited about the work here and are really very anxious to get to meet all of you.
Thank you. Thank you guys for coming on. I know you've been with us since the start of this meeting. Beth and Elin, I saw you early on, so you're getting a flavor for our information dissemination processes today. So thank you for sticking it out. Next slide there a little bit. So just to, Dan had described the functions of the contract, but we also wanted to share with you what that changes for our division staff. So Dan had mentioned, and Kim earlier, the clinical RN component of the mortality review. They will be taking that on from the current quality program RNs who are doing that as they expand into the HRSA clinical reviewer role, which is become a much bigger expansion of the role than we'd originally anticipated. So it's going to share that resource and allow them to focus on the HRSA. The management of the facilitation of the due process review committees from the quality programs QES team. As Columbus comes on and focuses on the facilitation of the due process, the quality programs QESs in turn are going to become subject matter experts on individual rights and due process and be available to consult with providers and targeted case management entities to help mitigate increased understanding and education of what a rights restriction is and when it's not appropriate or what alternatives might be. Some more information to come on that. The provider annual performance reports, which is coming from the quality programs QES and provider relations, and the provider site review that provider relations is currently doing. In conjunction with that, as Dan mentioned, they're going to be very similar and often the exact same tools PR was using, but this review process is much more robust. It is looking more into HCBS. It's looking more into systems. It actually interviews individuals as part of the survey process with a tool called the CAPS. So you'll learn more about that if you come to meet us at the meet and greet as we walk around the state. In turn, as Columbus comes on and we onboard them and they're very comfortable in their role, provider relations will be migrating into the purchase of service reviews that we all used to know and performed by the business office. That will now be provided by provider relations, as will a new review of service providers that are not covered by Columbus. So we currently do not have a quality assurance process around our providers who only offer therapeutic services, only offer durable medical equipment, assistive technology, transportation. There's currently no review process for those service providers who only focus on those. And provider relations will be designing and implementing that. So this contract with Columbus is really allowing us to expand the amount of quality assurance that we offer to all of our providers and assuring that services are being delivered according to the waiver. And then we have the TCM annual review that Dan mentioned is going to transition from the tax. In turn, the tax focus isn't really going to change. It's just that the weight of their focus is going to be much heavier with the onboarding of additional support coordination across the states as we continue to privatize more cases to decrease the average caseload of the state support coordinators. So the tax are going to have an increase in that workload relating to waiver assurance and their technical assistance efforts with those entities. And lastly, this isn't a transfer, but I didn't want to create a third column. We currently have one provider providing intense therapeutic residential habilitation, which was a new service. And it's required in that service to have an independent review of the service delivery, and Columbus will be providing that review of that service. Next slide. So just a little bit, just a brief and simple timeline of where we're at and kind of where we're going. December through February, we had multiple meetings. We started looking at processes and tools, access for you providers who have accessed our system. You know how challenging that can be. So getting access to non-state employees is equally as challenging, if not more so. So we're still working through some kinks in that. In March, we're going and doing the walkabout and the meet and greet. Columbus is doing training with both the tax side and the provider relations side. And as Dan said, they're shadowing the TCM review process. In April, the TCM review process goes live. We'll be piloting the provider site review and be hosting web events for those of you who are not able to make the in-person meet and greets, because those are limited in scope of who can attend due to the size of the meeting spaces we have. Our target for our provider site reviews to go live statewide is May. And then in June, we'll be finalizing all of those other, after we have access and training, and some of the other components necessary around due process and mortality review. They may implement before June, but we don't really have a hard and fast timeline. So it's our goal to have the entire contract online and actionable by the end of this fiscal year. And next slide. Just a brief overview of the meet and greets, of where we're going to be in the last week of March, first week of April. It's going to be a very ambitious schedule, and we're looking forward to seeing as many of you as possible there. So, all right, I'm going to scoot into the MOS update after I do, I think looking at the questions, there was a few questions. The TCM annual review tool has not changed and will not change. They are going to accept that tool. They are going to utilize the exact same tool that the TCM tax currently review. For providers, we're going to provide an overview of the process at the meet and greets as we walk around in March and April. Many of the tools are exactly the same that we currently utilize, but there will be expansion. They're in the process of working through the order and design of those tools and kind of merging them into one. But we will host a WebEx if we don't have that all perfectly lined out before our meet and greet. We will host a WebEx that just reviews the tools in general. And then we'll look at that. All right, I think those were the only two questions related to that. So thank you, Dan and Elin and Beth. I super appreciate you coming on and meeting us. And I will talk to you tomorrow, I think. And
Fabulous. Thanks.
so our next topic is the MOS. MOS. I pronounce it differently every time I say it. And a few updates for you. So next slide. We wanted to share with you a little bit. I know people are really struggling about the differences between the MOS, the MOCABI, the RAS, and the PON that we used to know and love. And so we thought we would just try to describe some of the differences and why you're seeing different results through the MOS than you did from those other documents. So it is not the same tool. It is not constructed the same way as the MOCABI. It is completely different and measures the functional limitation in a different way. And I want to illustrate that with some examples for you. The MOCABI was designed to determine functional limitation by criteria. Either you could or could not do something. That's all it was looking at. Either you could or could not tell time. Either you could or could not count money. It did not measure that person against other people of the same age who also have a developmental disability to determine whether there's actually a functional limitation there. So I'll give you an example there. In the MOCABI, you either, let's look at mobility. A 6-month-old would register as a functional limitation under mobility because they couldn't ambulate. Well, no 6-month-old can well, there might be somebody out there, but it is extremely rare for any 6-month-old to ambulate independently. So that really was not a functional limitation for a 6-month-old. But the MOCABI did not allow for that differentiation of age and expected ability of someone of that age. You either could or could not do it. So the MOS, by contrast, is a normed reference with a criteria-based section. So it provides a general comparison of functional ability among those in the DD population by age group. So it uses exercises from easy to hard to determine the ability in comparison to others with IDD. For example, 6-month-old, and you ask them a basic mobility question. No, they cannot stand on their own. They cannot stand independently, but no other 6-month-old can either. Therefore, it's not an area of limitation yet. Same thing for a 5-year-old, telling time. In the MOCABI, you ask, can you tell time? Can you recite to me these words? Most 5-year-olds cannot do that with or without a diagnosis. But the MOCABI didn't differentiate between that. You either could or could not do it. And so now the MOS is a tool that differentiates. They start slow, or a low question, and it builds like an IQ. It's asking easy questions to hard to see what is their limitation in comparison to people of their same age with an intellectual developmental disability. So it is much like an IQ test or an adaptive behavior test or other psychological tests. And I was asked this morning, shared with me that there have been some clinicians from a few places who have asked about the MOS. So I wanted to share with you all that the MOS took almost 5 years to design because it is a normed reference tool. You first norm it with a population that does not have IDD, and then with the population that does with the same group. The tool was designed by 3 PhDs, 3 psychologists, covering all of the areas of specialty. In fact, some of them were in school so long that they covered all of the areas of specialty. Psychological assessments, school psychology, and neuropsychology, and counseling. So there were 3 PhDs who covered all of those areas and a master's level licensed professional who designed this system. So it is a legitimate and valid tool developed by people who have the necessary criteria, experience, and focus areas to design such a tool. In fact, we have other states who are interested in utilizing our tool because it is a discriminatory tool, not just a you either can or cannot. So next slide. The other thing that is different, and I know terminology is problematic, but there is no MAS score. The MAS is the tool that then scores are derived from. So there are MAS derived scores. So many times people say they had a MAS 5. That doesn't really tell me anything because the MAS doesn't generate itself a score. It generates 3 pieces of information. It generates a rate allocation score of 1 through 5. It generates a priority of need score 1 through 5. And it generates how many of the 6 areas of limitation exist. So when you're saying they had a score of 5, was that a rate allocation of 5 or was that a priority of need 5? There is a difference. As it's generating 3 different pieces of information from one assessment, some questions might only apply to one of those assessments, while some questions apply to all 3. That was part of the design. And so we also get questions about, so my person has 5 areas of limitation and I have this other person that has 3 areas of limitation, but the person with 5 areas of limitation has a lower rate allocation score. So there's a reason for that. Remember that it's determining their level of support needs. So a person who has 5 areas of limitation may not need significant support in those areas, but you could have somebody who has 3 areas of limitation who has total support in those needs, and that impacts their PON and RAS. Remember that there's also that component of those criteria-based questions. Someone could have 5 areas of limitation, but they're being supported at home, and they have no emergency criteria, and therefore their priority of need is going to fall between 1 and 5. A priority of need 5 can only be reached by one of those selective criteria where you indicate, are they an A, B, C, D, whichever that is. So you can't reach a PON of 5 naturally through the assessment. You can only reach that PON of 5 if one of those criteria exists that you're selecting. Next slide. So some of the things that we wanted to share with you is other differences. The MAS is normed for virtual delivery. So we've been asked about utilizing other types of delivery. It's the part of norming a tool is doing it with the intended delivery method. So if you change the delivery process, you have to re-norm the tool. So we're continuing to look at other methods of delivering the MAS, but all of those methods have to, any additional methods have to be renormed for validity. So on the priority of need, that we're determining now is based on the general level of ability. How much ability do they have in the area? How much support do they need? Whereas the old format documented, do they have unmet needs? Not how much need they had, not what ability do they have to rise to meet those needs, but it's just do they have unmet needs? So it's a difference. A priority need is looking at a different subject matter now than what it did. Likewise, the rate allocation score is based on innate needs. How much support does a person need to remediate the limitation, right? Provides an estimate of the support needs for those in residential setting, including a criterion-based measure of extraordinary medical and behavior support needs. So that really changed very little. RAS 1 through 3 is based on core criteria. You only reach an RAS 4 if you have extraordinary medical supports. And you only reach an RAS 5 if you have extraordinary behavior support needs. So the priority of need and the RAS are not the same thing. They are looking, priority of need is general level of ability that tells you where in the line of waiting do they fall with a need for service. The rate allocation is telling you based on their needs, what are those supports extraordinary or not. Next slide. So some of the things, holy cow, I think is that the right time? I am. Oh my gosh, I ran over. So something for you all just to be able to reference. We're working through obviously onboarding. We've performed, those numbers were from 2 weeks ago. So that number is more around 1,800 now that have been performed since January. Working on glitches, we have people multiplying the same number of one person scheduling 18 times for the same person is eating up time blocks in Calendly. We also have people who are scheduling for MAS when they don't have to. If you are just needing to update the LOC, a Mokabi that has not expired works. You do not need a MAS if you are just updating the LOC and your Mokabi has not expired. So we suspicion we have a number because it's a much higher number than we had anticipated. So we anticipate that we have a number of people scheduling for MASs that are not necessary, but we don't have a way of knowing that. So if you have a Mokabi that is not expired, you do, which expiration right now is 3 years. 3 years from time of implementation. So if you have a Mokabi that was done 3 years from 3 years ago, and you do not need a PON or an RAS, you can use the Mokabi you currently have in file. You do not need to ask for a MOS. And the last thing, because I know I'm running into Julie's time, is it's essential that if there is a critical service situation, that you need to indicate that in Calendly. We have a number of people who are not indicating critical service situations. If you don't tell us it's a critical service situation, we won't ask you the questions that lead to that 5 on the PON. So please be sure that you're filling out the required fields accurately. A few more things there I hope you guys can read. Next slide is a little bit on the LOC. I'm just gonna important thing. Sorry, back up one more just so they can see that. Effective immediately, instead of emailing the supervisors of the assessment team, please use that box, dmh.dd.mos, for any emergencies. If you have an immediate need for a MOS and there's no Calendly openings, if your MOS is performed on a person receiving waiver services and you do not have 3 areas of limitation reflected, if there's questions about a person's specific assessment, if there's an emergency, a change in a person's status requiring immediate action, or if you have questions about the assessment, please send it to this box instead of to the assessment supervisor. Sending it to this box will go to all 3 assessment supervisors, and that way they can all work together to answer all of the emails. And if one is out, the other 2 can tag team and bounce in and answer the questions on behalf of that person, so we can get you answers faster. So I'm sorry, Julie, I took up some of your time. I was trying to pay attention, I lost it. So I'm going to skip the next 2 and I'm going to hand it to you, Julie.
Thanks, Wanda. Well, I think I've been allotted more time and I won't need as much, so we should be good. My name is Julie Peterson. I'm the Director of Fiscal Operations for the division. I'm standing in for Angie Brenner today. I'm going to give a brief budget update and a little bit about the rate refresh. The budget for the fiscal year, sorry, and I'm going to have to get used to this. I'm used to doing my own. So there you go, slides. So the budget for the fiscal year that begins July 1 of this year is moving its way through the legislature. Here are just the links to the various budget documents, including the FY24 governor's recommendation for our division's annual budget. The supplemental budget items, those that we request funds to supplement the current fiscal year. So for fiscal year 23, these have been presented to the legislature, and the early supplemental in House Bill 14, which contained the statewide pay plan increase, was actually approved by the legislature and signed by the governor recently. Regular supplemental requests include funds for overtime for our state operated facilities, contract staffing also at our state operated facilities, a technical correction for a fund transfer for the provider relief funds we've received, and then of course some moving expenses to relocate some of our administrative staff off of our HAB Center campuses. Those are the big dollar items. Moving into the actual budget. So each year, there's a lot of budget terminology, but I'm just going to kind of boil it down a little bit for you here. We have what they call new decision items, not necessarily new things, but they need more or additional funding. Within DD's FY24 budget, new items for decision, basically it's a decision item, include a request to fund increased utilization of the DD Health Net programs. We have projected the new number of individuals by setting here. We're projecting 1,140 in-home and 445 residential. And then of course, care plan increases for the individuals we served in the prior fiscal year. We also request ongoing general revenue for those home and community-based services provider rate increases, our rate standardization, and a portion of the DD value-based payments that were related to rates. These were funded in the current fiscal year with one-time HCBS enhancement funds. And we did also, there was a small portion in FY22 that was funded with one-time funds. So we're just trying to get this picked up in ongoing funding. We've also requested ongoing funding to meet the costs to continue for the division's value-based payment initiative, again, that aims to achieve positive quality outcomes with high quality service delivery, again, funded with one-time money in FY23, working to get the pickup. And again, another cost to continue. We were awarded in the FY23 budget funds for home and community-based service enhancements that were related to increasing the cap or the max for home modifications and for the enhanced provider reviews that we're currently in the process of implementing. And again, it kind of sounds like a broken record. We were funded the item with one-time funds. These are essentially asking the legislature to now pick these up with our ongoing funding. And we talk about the moving expenses. These funds were to relocate administrative staff from Sykeston and Poplar Bluff regional offices and at the Northwest Community Services. It's the state operated provider in Northwest Missouri, from HAB Center campuses onto leased or state-owned facility space. And so the funding is just simply for one-time moving and furniture costs there. And then finally, you have the DD Health Home. We are requesting funding to implement the DD Health Home initiative beginning in FY24 that will provide care coordination for DD individuals with chronic health conditions. I believe Leslie covered this earlier, an update for the DD Health Home. Next slide. And we can go through these next two fairly quickly. This is just kind of letting you know where we've been so far in the budget process. DMH has presented the budget, both divisions, to the subcommittee and the House and Senate committees, and the supplemental hearings have been held. It's been a busy session. Here's the calendar so far with the actions to date. The Missouri legislature is on legislative spring break this week, hence Angie is not here, but things pick back up Monday because we will have a House budget hearing beginning at 11 a.m. And next slide. Public testimony happened on February 1st. And then the early supplemental bill again, that included the pay plan increase, was signed by the governor on February 27th. A House budget markup is in the process. Again, we have another hearing on Monday. The subcommittee did have one amendment to our budget thus far, and that was to add $100,000 to true birth sclerosis. research and remove the limitation for funding that currently is provided to only one area in the state. So again, that's an amendment, still has to go through the process. Thus far, that's our only addition. And that's kind of the basics of the budget. As we move into, go ahead and next slide. The rate study refresh, I just kind of want to mention a brief update. As you know, CMS requires states to perform rate studies at least once every 5 years. The division enlisted the state's actuaries and to perform a rate study refresh in 2022. The stakeholder presentations were held on August 19th and November 10th, and links to those presentations are here. A stakeholder meeting was held in conjunction with the presentation on November 10th, and stakeholders were asked to provide feedback by November 23rd. The rate study is currently being finalized to share with providers. And on the next slide, I'll kind of briefly cover some highlights from the rate refresh. The current rate is $15 an hour starting DSP wage. Based on the rate study, the market rate wage is $21 an hour. And the estimated fiscal impact to increase rates from current $15 to $21 an hour starting DSP wage is about 185.5 general revenue. That's state dollars. The total would be 544 million roughly for both state and federal. And some facts and figures here to support kind of the discussion around the workforce shortage we've captured here. The national average turnover rate is 43% nationwide, and our NCI survey shows Missouri at 58%. So 38% of our DSPs have been with providers less than 6 months, and only 13% have been with them over 3 years. So we have this fact compounded with, I think this says 647, but I think the last update was 653 people either needing a residential service or wanting to switch to a different residential provider, with 49% waiting for longer than 6 months. These are all considerations when we're talking about the workforce shortage and its impact on the individuals we serve and to the Medicaid HCBS system as a whole. So that is the fast and furious of budget right now. So happy to take any questions, or if I'm the end, everybody, how'd I do? Oh, only 2 minutes over. I think I talk fast.
You did wonderful. Actually, thank you all of our panelists today for your support and sharing all your wonderful information. And the next round of we'll meet a big group again in about 6 months, but look to your regional staff to do meetings for providers within the next 3 months or so. And then, of course, please come see us during the Columbus meet and greets and the walkabout across the state. We're excited to meet you all and have you get to know Columbus. If any questions weren't answered in the chat, we'll be reaching out and answering those questions. So thank you everyone so much for your time, and have a wonderful afternoon.